not readily available is the tablet. So for children that maybe a child of 8 kg that is taking less than 200, you may have to send it for compounding. If you say the mother should cut it, she may not cut it appropriately. So this is the picture of the tablet. I think it looks like this, go? So, caution, when you are giving somebody, when you are treating somebody for schistosomiasis, you have to be cautious of this. You can, the patient may present and may have, when you start treatment, when you give treatment, the condition may even be worse. I think even malaria, I used to give that sometimes. When you take the drug, you feel like it's even getting worse.
Especially the cases.
Yes. So, and there are many even chronic infections, even TB. And HIV, when you start treatment, you see that the sickness is even becoming worse. So you can have that one also with schistosomiasis. When you give the treatment, maybe in the next 2-3 days, you see that the condition is even getting worse. Because the parasite have to struggle also. Your immune system also have to struggle. So this is suspected to be due to release of the somal antigens. As you are treating, you are killing the parasite. The component of the parasite is released into the circulation and they are eliciting a lot of reactions. They are releasing of, it's like these bandits, the more you kill them, the more they want to show resistance. If your village kills some of them, when they want to reprisal attack, is usually deadly. So this one too, you are killing it and the killed parasite is releasing some, is getting destroyed and the content is released. It usually occurs during the acute phase of schistosomiasis. So those that are already having chronic presentation, they hardly have this clinical deterioration. What are the side effects? I try to divide it with the time that you give the drug, or the percentage, their frequency, possible, those that can occur in 1 to 10%. That means if you treat 100 patients, you can have one or up to 10 patients that will say they have this side effect. Some will come with loss of appetite, dizziness, drowsiness, headache, malaise. What is malaise? I think just feeling weak. You feel like kamakata hayakin dunya, very weak. Abdominal pain and nausea. This vomiting and diaphoresis. Then there can be CSF reaction syndrome. Though this is CSF reaction syndrome is noticed in patients that have cysticercosis in the brain. That is, these liver migrants we mentioned is the liver also that got trapped in the brain, and when they have it, it can cause this CSF reaction syndrome. What is diaphoresis? No, I'm not. We have to blend. We have PHC and doctors here. In fact, in one of the states that they are doing this training, the state ministry say no, they have to do it separate. For PHC workers, I said no. In Zamfara, our PHC workers, some of them, they are very sound. Oh, I think I'm saying the truth. Yes. I am IMCI trainer. I have seen many faces here that we interacted. From here I can see some. So diaphoresis means excessive sweating. Somebody maybe is chill, is not, but you just see him sweating. So after this, taking this drug, 1 to 10% can have that. Then side effects that occur is less than 1%. Does that if you have 100 patients, you may not have anyone. But if you have like 150 or you may have one, or then diarrhea. Those ones, some will have diarrhea, some will have fever, some will have itchy rashes. Rashes will appear and they are itching, and some will have urticaria. What is urticaria? It has name in Hausa. Yes. Samiha, yawa. You are from which local government? In my local government they call it Samiha. It's Samiha. Some after taking this drug they will just come with rashes. Samiha, itchy, some will be scratching, and so that's urticaria. But this occur is less than 1%. What are the other side effects that we are seen after even, there is what we call post-marketing. Side effects that were not recognized during the, what we call it, we have 4 phases of clinical trials of drug. So, but even after the drug is licensed, when people start taking it, you have to follow up for some years. So these were noticed post-marketing. Some pruritus, just itching, there may not be rashes, rash, abdominal pain, anorexia. We send nausea there. What is anorexia? Nausea is just feeling kamakai amebo, while anorexia is just feeling you don't want to eat food. Zaka ji baka da appetite, kawai kai dai baka son cin abinci. Bloody diarrhea, vomiting, allergic reaction, arrhythmias. When we say arrhythmias, we mean abnormal heartbeat. It can be bradycardia, it may be low, it may be ectopic rhythms. These can be identified with ECG, ventricular fibrillation, and AB block. What is the significance of this is that if patient is having an existing heart problem, maybe an adult with hypertension, or an adult with hypertensive heart disease, or a child with congenital heart disease, or a child with acquired heart disease like cardiomyopathy or rheumatic heart disease, you have to be very careful when you are giving him this drug. You have to keep him very close to you if need be. You even send him to, don't give him paracetamol at your center. Let him come and see them where they will do ECG and other things and monitor because it can compound pre-existing problems. Fatigue I think is also just feeling weak, even small work. Somnolence. What is somnolence? Kawai jin kasala, kawai ka ji kai dai ba ma abin da sha ma kai kwana ɗaya kawai ko da yaushe. Asthenia. What is asthenia? Getting slim. Watakila ko da ka bashi yana da jiki sai ka ɗaya yana ta ramiya. Sai ce kai likita ɗin ga drug ɗin ga da Batago to vaccine. Batago I think when you see environment toning go. While what is it? Batago and drowsiness. Batago, you see the environment toning. You just see that this room is toning. While dizziness and drowsiness is more of just okay, you are the one toning. Compulsions. Really, some were noticed to even have compulsions. Fisge ko mai higiya, wasu na ce mai bugun sunsu. Wasu na cewa mai higiya, wasu na cewa bugun inna. Amma mayaljiya za ka ji ɗaya tsokanka tana ciwo, ba ƙashi za ka ji yana ciwo ba joyin ba kuma, a nan kawai za ka ji ko ina naka. Duk waɗanda an yi reporting ɗinsu bayan drug ɗin ma an yi licensing ɗinta, amma very rare. What are the contraindications? Me zai hana ko ka diagnosis wanga schistosomiasis in kaga waɗanda maybe in patient ya ce ma kai kana ɗaukar drug ɗin na ce Allah da na sha ta shekara baya Allah ɗaya sai da na fi mutuwa. maybe an yana sha ya yi collapsing ko ko duk kaga ko ina kuraje ya zama bai kun dai san hypersensitivity reaction. So those that have reacted to the drug previously is contraindication, and then those that have intraocular cystic psychosis, akwai waɗanda cikin idanunsu waɗannan labi ɗin da mun kace suna iya shiga cikin ijiya, to an yi confirming wannan ne sai an je wurin ophthalmologist. in mutum yana da shi ma ba a bashi wanga drug, sai an yi titikin kiya ɗin wancan abu. sai kuma concomitant use with strong cytochrome P450 inducers, akwai maganunuka da ake ce masu suna inducing. Example shine rifampin. Ina muka amfani da rifampin wajen tuberculosis. To in mara lahiya yana da tuberculosis kuma ka gano akwai wanga schistosomiasis, ba za ka hada su ba don za a iya samun serious problem. So pregnancy, published studies have not identified association with use during pregnancy and major birth defects, miscarriage, or adverse maternal or fetal outcomes. So that means this drug is safe, even in pregnant women. It's safe in the woman and it's safe for the baby. There are drugs that are safe for the woman during pregnancy, but they are not safe for the baby. The baby might be delivered with some problems. Those problems might be lethal, might be a just mild problem, like tetracycline. If a pregnant woman takes tetracycline, the child can be delivered with stem teeth, stem bones. So that means if the woman is between life and death, and is only tetracycline will save her, you can still use the tetracycline. Because if she dies with the baby. It's better the baby die, you can manage the colored teeth. If he's a man, let him go and look for money. You will get the most beautiful wife. So that's, but there are those that are either disabling or lethal, like thalidomide. It's safe to the woman, but when they give to pregnant women, they deliver with children that are not having hands. And not having hands is very, yes, pecomelia is a very serious disability. Or some, the baby may even die or get aborted. So this one is safe. So, what about a woman that is lactating? We said in pregnancy is safe for both the mother and the infant. It has low concentration in milk. No reported effect in milk production and no effect in the infant. So when a woman is lactating, is breastfeeding, it doesn't reduce the breast milk, and the concentration is low in breast milk, and it is shown not to have any effect on the infant. You know there are drugs that you can use even in breastfeeding mother, like cytotoxics. I think you don't use cytotoxics in breastfeeding mother, and even lithium and some other drugs. So what about if you mistakenly give overdose to a patient instead of giving, because in some tests you will see that they will write 60 milligram per kg per day. When they say 60 milligram per kg per day in divided doses, that means if you are divided it into 3, you give 20 milligram, and you do not see till when you give the patient the 60 milligram, you give him 60 milligram per kg per dose, and after taking it 60 milligram 3 times, the next day he come, you remember that when you look, you see his body instead of per dose. That is overdose. Those one, if the patient did not complain of anything, no any problem, just keep quiet. You can give him short appointment. But if he presents with serious symptoms, please rush, refer him to hospital where he can be taken care of. And those can be difficult breathing, collapse and other trouble symptoms, or even convulsion. When you see those ones, please quickly arrange for him to be rushed with ambulance to a tertiary center where his breathing, everything can be taken care of. What about measles? You have given somebody, you said you should be taking 6 hourly or 8 hourly in 24 hours. He has taken the next dose, he did not take. What are you going to do? I'm taking my time to say all these things because of the PHC, this thing that we dealing directly with the community. And you need to understand all those things for them. When they miss, let him take it as soon as he remember. If you say 8 hourly and he took the dose, maybe he took the first dose 8 a.m. The next dose is going to be what? 4 p.m. But he did not remember till 6 p.m. He should take it at that 6 as soon as he remembers. Yeah? If it is close to next dose, now if he missed the 4 p.m. dose, he's supposed to take the next dose by what? By 12 midnight. So now he did not remember till 11 p.m. Then he should just skip that dose. Take the 12 p.m. on, and then check the next dose after 8 hours, 8 in the morning. So that you know the risk here is that he can take that 11 p.m. and still take that of 12, and that may have sign of overdose. So he skip. That means do not double the dose to catch up. You couldn't remember the next dose is maybe 8 p.m. And you do not remember the 12 noon drug till 7 p.m. Don't take that dose at 7 p.m. and then come at 8 p.m. and take another dose. No, wait, just forget about that one. You take it 8 p.m. on, and then the next one you take it 4 a.m. That's what this statement means. How do you store the drug? I'm still talking to PHCs because you are the one that they may likely supply this drug. If they give you this drug, or even the patient you are giving, if you are giving him 3 tablets, he should store the drug at room temperature. He doesn't need to have fridge. Even if you have fridge, you don't take it to the fridge because fridge, the moisture will spoil it. At room temperature is normal temperature, away from light and moisture, and don't keep it in an open place. Light can deactivate the drug, and even moisture will spoil it. And you should know, keep all medicines away from children. And many health workers used to make that mistake. You keep drugs to the reach of children. We have seen many children that will go and take drugs. We have seen many children that they will go and take Fesolate given to their mothers. You know Fesolate, the color is red. Red color is one of the colors that children like. Pink, blue and other good colors, shiny colors. That's why you see us pediatricians, we also like those colors. Children like them. But they don't like white color because all the nurses that inject them, they are wearing white. So immediately they see white, they run away. So many mothers will keep Fesolate. Fesolate is red, and they see the mother taking it. And when they take it, some of them are coated with sugary cotton. And you see many children taking overdose of iron, and it's deadly. So, and this drug is one of the drugs that sometimes are flavored to encourage children to take them, like the way we have flavored albendazole. So, flavored Septrin for children with HIV infection. We all have them flavored. And when they they take them and they are flavored, they will just be taking them. So don't keep them close to children. If they give you in your peer, please keep them away. If you are the one giving to them, keep it away from children. Don't say I'm biased. I do not say keep away from adult. If you like an adult, go and take one ticket. So these are the complications. Who asked of complications? I just mentioned the complications. Some of them, many of them, when you see them, you refer to patients. Many of them, the diagnosis is in tertiary centers. Bladder calcification, that one, Dr. A. Guso is here, that's their work. You do X-ray, you do ultrasound, urethral obstruction, you do ultrasound, and you even do some specialized X-rays like MCU because there may be backflow, hydronephrosis, hydrouretus, bladder wall thickening, and other things. Nephrotic syndrome too, this one too is more of tertiary, that in your center what you can do is when you do your analysis and you see protein 3 ploses or 4 ploses, please refer that patient to us. Nephrotic syndrome, they can is a part of the complication. Secondary nephrotic syndrome, pyelonephritis, patient coming with flank pains, serious pain. Pyelonephritis can present as acute abdomen. Many people will rush and say, especially if it's the right side, and go and do surgery for appendicitis. If you open that patient, just remove the appendix, but treat for this one doesn't need surgery. It's more of antibiotics, hydration, and other things. But those ones to pyelonephritis, apart from the lab investigations, the radiologists also, radiologists, they are multi-purpose. They have to know, I don't know whether they need to know everything. Knowing everything is only God, but they have to know as much as possible. Severe anemia, as we said also, because they are having hematuria. And then, if it's an adult, by the time it's becoming malignant also, and they can have so PCV. That's why we said you need to do PCV again and identify whether they need blood transfusion or whatever. Hematuria is even part and parcel of the sepsis. Patients that have schistosomiasis are found to have higher risk of having salmonella infection. So typhoid fever, especially in children, typhoid enteritis, typhoid perforation, and other typhoid. So we don't even know. Probably that's why we are getting. I believe all the doctors here, they can see many, especially around this time, a lot of cases of typhoid enteritis and typhoid perforation. My Oga is there. I know that Dr. Augustine. That time that we were together, you hardly spent a week without having a case of typhoid perforation in children. So it might be concomitant infection with schistosomiasis, which I know the area we are practicing that time is one of the areas that have very high risk of this schistosomiasis because a lot of water bodies, padama and other things. So bladder cancer, this is the Oga Patapata, and that's one of the main essence of this presentation, of even this training. NICRAT is National Institute for Cancer Research and Treatment. So this bladder cancer is the reason why we are here. The schistosomiasis is an attachment. But this is the reason, is to prevent this one. That's why I left it at last. And the subsequent modules are all module 4 and 5 are on bladder cancer. So these are the complications. As a pediatrician, I'm very much this is one of the main targets of this presentation. Bladder cancer, you need to know what it is and whatever, but the treatment and management, I think, is more of tertiary centers. But what we can do at PHC level as primary health care is to try our best to see that we control this schistosomiasis, so that the patient will not even have the bladder cancer. So, how do we prevent and control the schistosomiasis and as well the bladder cancer? I use 5 levels of preventions. That's the one way the pediatrician prefer. Level 1 is general health promotion. In this one, anything that promotes health. What you target here is not specific to schistosomiasis. And in this one, you encourage people to have access to safe drinking water. In the village where you are practicing, if you are see them, they are taking drinking water from the font. Encourage them to boil it, filter it before they drink it. That's access to drinking, to safe drinking water. And to some extent also, government has to come in here. Improve sanitation, personal and environmental hygiene. Improve sanitation, we shouldn't be dumping things everywhere. And when the rain starts, they will wash away all those things into the water source, into the ponds, and the ponds get contaminated. Personal and environmental hygiene. When you go defecate or urinate, make sure you wash your hands. Don't go and defecate or urinate where the village from their water source, where they carry their animals to drink water. Because when they carry their animals to that fresh water to drink, they also have to enter that water. Because when a cow or a donkey enter the water, you have to enter and bring the animal out. Is that not so? Don't go and be urinating where people, the village people, are going to wash their clothes, or they go there to bath. So all those environmental hygiene. And then we need behavior change, open defecation, open urination, dumping things. Even some will shit and urinate, put it in nylon and go and discuss into waterway. Some will even go when government constructs, what do you call it in Hausa Labatu? Somebody will just go there and defecate, let the something follow water and urinate, and the water will end up in the pond. And when you urinate, you are releasing the eggs of this soma hemat. So we should have behavior and even social control. So all these are at level 1. All these things that we are going to do, they are not specific for schistosomiasis. They can also help in controlling cholera. Is that not? They can even help in malaria, allowing bushy areas, all these things, open water bodies and all those. So many diseases can be prevented at this level. Then level 2, that's where we have specific, something that we do directly to prevent schistosomiasis. And the World Health Organization strategy for schistosomiasis control focus on reducing disease through periodic targeted treatment with parasite control in endemic areas. And we so far mentioned that 51 countries are endemic countries and they need periodic chemotherapy. And one of those countries is in Nigeria. And one of those states in Nigeria that need that preventive chemotherapy is Zamfara State. Already, thanks to the PHC, they said there is already ongoing, and to Dr. Aminu, targeting primary school pupils and secondary school students. So, and that's what we call preventive chemotherapy in affected population. And what are the groups of people that are targeted for this? One, we have preschool age children. Who are the children that we call preschool? Though even the preschool now, they are school. People are taking their children. Some children, when they tell you the class they are, you wonder whether since the neonatal period they were enrolled in school. But ideally, preschool is like below 5 years, 3 to 5 years. 2 years, toddlers that they go to buy it. So they are either fishermen or farmers that are involved in businesses associated with these waters. So in those communities, you can give all the community members. But in those that are having moderate and low transmission, that's you target the risk, people at risk. In high transmission areas, treatment may have to be repeated every year for several years. So yearly you give them paracetamol every year till maybe they reach the stage for several years. The aim is to reduce disease morbidity and transmission towards, as I said, if they are adult, they are at risk. If they can't have the complication, there will be distributors of the disease. In fact, there will be wholesale. So, transmission towards elimination of disease as public health problem. Periodic treatment of at-risk population will cure mild symptoms and prevent infected people from developing severe, late-stage chronic disease. Level 3 is early diagnosis and treatment. And at this stage, you should have high index of suspicion. As I said, any patient that comes with bloody urine, irrespective of whether it is terminal, initial, whatever, please do urine microscopy for schistosoma over. Any woman that comes with contact bleeding, do it. You should have high index of suspicion, especially people that are from the high endemic local government. Yes. Then level 3 is limitation of disability. What it means there is by early management of complications, timely and appropriately. Somebody presenting with psoriasis and is having severe anemia, please transfuse. Because if you don't transfuse him, he continue to have that. From that anemia, something can come up, heart failure can come up. And if you continue to be anemic, he is also at high risk of getting other infections. If they come with salmonella or typhoid enteritis or whatever, also treat appropriately, because there is also synergistic effect between psoriasis and salmonella infection. So, and all other complications that we mentioned, if they come with them, appropriately manage those complications. If it is obstruction, send them to the urologist. They know what to do to relieve that obstruction. So it's because if you don't timely manage those complications appropriately, that's from that obstruction it can lead to chronic kidney disease. From that contact bleeding, it can go to infertility. So the level 5 is rehabilitation. Some you may not even see them till at this level, where they already developed cancer or they already have chronic kidney disease that they need what? Renal replacement therapy. And you have to send them to centers where they can assess that dialysis and finally renal transplant. And which you know, our people, many of our people, they don't have money for that. It's like anything that need clinic kidney is like a debt license. Because you need to look for millions. Even the dialysis that is somehow available is very expensive. It's how much? It's 30-something per session, 30-something thousand, and in a week the patient may need 2 to 3 dialysis session. That is 100 and something thousand. Apart from other drugs, the erythropoietin.
If the machine is not broken.
Yes, so it's not easy. With this, I will say thank you for your time. Questions, comments, contributions. My chief, if you ask question, is back to Sandal. You answer
Thank you very much, sir, for the presentation. My question is the treatment of urinary cysticercosis. In the treatment, sir, you made mention of some drugs that are contraindicated, like rifampin, for example. And we can actually have patients that are on treatment with rifampin or other drugs that are cytochrome P450 enzyme inducers. And I need clarification whether that contraindication is a relative contraindication, maybe if there is room for dose adjustment to the dose of praziquantel to meet up with the effects of those enzyme inducers, or it's an output that might necessitate change in the other regimen. Thank you.
Question, comment, contribution?
Maybe this is the fault.
which drug agent that you can, especially in HIV patients? Which drug is rifampicin and
There is isoniazid and
okay.
pyrazinamide.
No, there is one. This required the exact time, but I don't. Is this up to 2 weeks?
That's potassium.
Yes. You suspend treatment for the TB for some weeks, for some days. You give this the praziquantel, and after those days you continue. You get me, because the cystomiasis too may be a deadly presentation. Yes, and you know one good thing about this praziquantel is only for a day treatment. Yes, but I can't remember the specific number of times. Maybe I will check later. Please, we are sorry we did not announce that we need to have people that will present the cap to us tomorrow. And we have gone far. So, but I think we have people that have very good memory here that can remember all what we have done. And we need to have a leader where who will create WhatsApp group for us, so that even after this program, we can disseminate information, we can even disseminate the slides, and some of these questions that we don't have specific answer can be answered there. I will check those number of resting period that you will give. So, thank you.
Sorry, sir, because I'm going out. My question is regarding for the last discussion you did. You say you have a patient with a TB. So you want to give that TB praziquantel. You say you should suspend the TB drugs. So in TB drugs, maybe the patient is intensive pace. If that patient is intensive pace, it's complete 4 months. So you suspend the patient to taking that drugs. So how can you that patient to go out the remaining days he left?
Sorry, maybe you did not. I don't mean to stop the whole anti-TB, is the one that specifically have this issue. And even in the treatment of TB, there is room that if a patient skips some doses, there is number of days that you don't need to go by, you just continue. And there is that number of time that when it takes more than those weeks, you have to start afresh. You get what I'm saying? If now somebody is taking anti-TB and something happened, he couldn't take for 5 days, all you tell him is to continue. Is that not? Who are in anti-TB program here? Is to tell him to continue. You don't say those 5 days, they all, like the whole this thing has gone.
So any data is repeat this.
That means is to continue. The only thing is now, like if you are saying it's in intensive phase, it's 2 months. It's 2 months. But something happened. Maybe he traveled, and maybe he traveled with the intention of spending a day, and he did not carry his drugs. Or he thought he carried his drugs. He intended to travel for 5-6 days. And he thought he packaged his drugs, only to go there, he did not see those drugs. When he comes back, what you will do is to tell him to continue, that you remove those 80 days, those 5 days that he missed, they doesn't count. You don't count those days. If he has taken for 20 days, that means those 5 days have gone. You don't say it's 25 days. You have to complete the remaining 60 days for him to complete 2 months. That's what it means. But you don't say no, the 20 days he has spent, they have gone. You have to start afresh. But there is number of days. That one too I can't remember specifically. But there is number of weeks. If he missed, he is to start afresh. You get me?
When he went out, he didn't say that. Remember, to take the protocol is just for ED.
Yes.
So maybe if you
I will look for how many testing days you have to take without taking that requirement. When we open the WhatsApp group, I don't want to give a purulent something.
Any other question?
Someone has the one that I asked TV is the TV program. Let him tell us how many days. You know, you want to tell us.
Yes. So if the patient default for 2 days of taking drugs, so you have to add 2 days upfront, not to take him back again. And the issue here is that rifampicin is combined tablet. It's not separated. It's rifampicin as soon as prasinamide and the etombitol combined tablet. That's where the issue is.
Maybe you give.
I think like you rightly said, it's better we go and clarify, but there is room for drug holiday. What is more problematic is taking one drug and not taking the other. But if you take a holiday for the whole drug, likely of resistance is minimal compared to just taking one drug and dropping one. So I think probably like rightly said, let's get the actual number of days that when you spend them without taking the drug, it's like you have to start afresh. But when you take drug holiday, there is room for you to restart and add up to your previous milestone you achieved. But I think this one, when we liaise with the ID physicians, we get more clarification so that our session for tomorrow will come with additional explanation. Before I give the mic, let me add something that you added when you mentioned salmonella infections and schistosomiasis. You know, salmonella literally is the typhoid, we call this typhoid. There are people you keep treating for typhoid, they keep coming back. And it's genuine, they are there. And this issue of salmonella schistosoma complex is there. So in this type of people, if you don't treat the schistosoma,
Don't know who will volunteer to be, or you want to select somebody to be the group rep. Or we will have a volunteer. So that one will collect all the numbers. The people that the number you are using for WhatsApp, so that we can easily disseminate information there. What is the time now? for afternoon prayer break.